Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I am Amanda Mixon, your host for today and the current president of RhAPP. We are here at our 6th National Annual Conference. It's been so exciting, and really we're trying to highlight some of the sessions. For this episode, it's titled Beyond Dryness, Key Takeaways from the Sjögren's Symposium at RhAPP 2025. We'll be unpacking highlights from the dynamic session held this year at this year's national conference, including fresh insights into diagnosis, disease burden, pathophysiology, and also the emerging therapies in Sjögren's. It's funny because for many years we didn't really talk about Sjögren's much because we didn't have much to do for it. Today, joining me is my dear friend, Betsy Kirchner, who is an amazing colleague at Cleveland Clinic. I'll let her give an introduction, although I'm sure all of you probably know her. But we're going to together unpack Sjögren's disease and talk more about it in our symposium. So Betsy, please introduce yourself.
Thank you, Amanda. So I'm Dr. Betsy Kirchner. I'm a nurse practitioner at Cleveland Clinic, as Amanda said. I've been in the Department of Rheumatic and Immunologic Diseases for about 25 years, and I have been honored to work with RhAPP for the past several years, and I'm very excited to be here.
She downplays her role. She was really the founder of RhAPP. I mean, I call myself a co-founder, but together we created kind of what this organization
is. And we always had a lot of help with amazing boards, and it's just...
I know.
It's our home.
It truly, truly is. It was so exciting when we were asked to do this presentation together because, I don't know, it just brings us back together, which is so fun. And really, again, it's about a topic that I think has really been underdiagnosed, obviously undertreated, but not because we didn't want to, but there were really no treatments for Sjögren's. Even changing it from Sjögren's syndrome to disease, I think, is impactful. How do you feel like Sjögren's disease has evolved over the years?
Well, I think the recognition has definitely evolved. And more importantly, the patient recognition has evolved. And here at the conference, we have the Sjögren's Foundation. That's an amazing nonprofit that gets this information out to patients and lets patients talk to each other. And I think organizations like that have gone a long way, where it used to be dry eyes, dry mouth, what are you going to do about it, to understanding that it's systemic and that we have FDA-approved treatments for these symptoms, and we have FDA-approved treatments that we use off-label, but we don't have an FDA-approved disease-modifying drug yet for Sjögren's.
Mm-hmm. And, again, I think that's what's led to such, challenges for patients. And I have to say, I said this in the symposium, but early on in my career, when I would see a new Sjögren's, I was trained and by an amazing rheumatologist, but that this really wasn't a big deal. And, just make sure you stay up to date with your dental exams and your eye exams and kind of monitor for lymph node swelling and off on your way. Obviously, we recognize now that it is way more there's more to it than being, this glandular disease versus this extraglandular disease, and they have different manifestations. So it's not just the lacrimal and salivary glands, but there are pulmonary manifestations. There are, neurologic manifestations, arthritis that goes along with. So, again, I think it's important that we recognize that it's not just about the dryness, right?
100%. And sometimes we don't ask patients actively. They don't know to tell us. They don't know to tell us they have tingling in their feet. They think it's something different. They don't realize it's related. So it's up to us to ask all those questions and to get the screening tests, at appropriate intervals, because it's just not as sort of famous and well-known a disease as things like lupus and rheumatoid arthritis. So it's really up to us, and it takes a team. We work with our ophthalmologists, we work with our oral health, professionals, the dentists, and getting education out there. We work with our hematologists when those screening tests come back not so great, and we're looking at a possible M protein. So it takes team, and it takes us kind of being the quarterbacks.
Well, and I have to, if I'm being completely honest, I have had people actually tell me about their tingling, and I have said, oh, well, just go talk to your primary care about that. Not really even understanding that that was probably a manifestation of Sjögren's.
In the old days.
Yeah. Yes. In the old days. Now I never do that.
No.
No. But I think it's really important. I mean, I think I've learned so much just in terms of like, preparing for this symposium, but also just the newer literature about Sjögren's. And, again, that it is multifaceted and it's not just about the dryness.
It is not.
Think about, though, what it does for quality of life for our patients. Obviously, we're here in Colorado, which is a dry area. So I do actually see a significant amount of Sjögren's. I don't know if that's partly because it is so dry here anyway, and so people are maybe more, in tune with that. What do you think how this impacts people's quality of life?
The most obvious answer is the dry eyes, dry mouth. And it's not just, your eyes are a little dry, they feel a little gritty. It's people having to change their jobs because they can't look at a computer monitor. It's, people saying, well, I can never drink red wine again. It tastes terrible. And it might not sound like a huge deal, but if that was important to you, if you're from a family where that's part of your social gathering, then it does kind of make you feel left out. Always having to be conscious, like, oh, they put out cheese and crackers at this party. Well, I'm not eating the crackers, because there isn't enough water around. It's always on your mind, and it becomes exhausting, I think, for patients.
Absolutely. I totally agree. It's really challenging for them. Some of them can't eat. I've had patients that, to your point, they cannot eat hardly anything, which completely changes their diet. And so much of social settings is food and food related. And if you are at the table but can't eat anything that's being served, that's extremely challenging and depressing.
Very depressing.
And I would imagine that a lot of our Sjögren's patients do struggle with depression. And even just from an aesthetic situation, I mean, a lot of them lose their teeth. And, as we all know, dental care is not cheap. And so sometimes they can't afford to maybe get, dentures or even things like that to where it helps with those things. So I just think, again, it's so multifaceted and these patients are really struggling. And I also think, to your point of saying, like, it's not just, oh, you're just a little dry. You could lose your job over this.
You could.
You could.
And then the fatigue that goes with Sjögren's can be debilitating. So on top of everything else, they don't even have the energy to fight.
Right.
Like I'm just not going to get dentures because I just don't have it in me to look up those, maybe community resources or dental schools or things like that. And so, another group that we can sort of rope in to help us is, social workers and psychologists, and try and get our patients hooked up there so they know that there is support out there in some locations and help them access it.
Absolutely. Well, let's kind of shift because obviously, I think because there's maybe some new therapies that are on the horizon, it's raised more education, I think, about Sjögren's. Let's talk a little bit about the role of B cells in particular. I don't know anybody that is as good at immunology as you are. And
you must not know very many people.
That's not true. And you know it because you're so smart. And and it's so true. And can you just help me understand a little bit about that role in Sjögren's?
Well, everybody in rheumatology knows B cells, produce the antibodies. They're central to all of our autoimmune diseases, not just in rheumatology, but neurology and gastroenterology and endocrinology. So B cells are sort of the central targets, and I don't want to say bad actors because we need them, but they're just a little overactive and they're pointing in the wrong direction. In Sjögren's particularly, there is an excess of BAFF and BLyS. BAFF, BLyS, same thing. So that makes a very attractive target. And it's already been looked at, actually. Belimumab targets BAFF and BLyS, not FDA approved for Sjögren's disease, FDA approved for lupus. And it didn't really do that well. And then they thought, well, how about, since this is such a B-cell driven disease, how about rituximab? And that didn't really do too well. And as we talked about in the symposium, it was when somebody came up with a 1-2 punch. They said, BAFF is sort of the super fuel of driving B cells into becoming plasma cells and churning out all those antibodies. So if we can cut off the fuel supply, that sounds like a good, way to go about this. And then, so that would be, the belimumab or belimumab-like medication. But we also have to do something about those B cells. So, you can get rituximab or other B cell depleting agents, but it seems to be the 1-2 punch that is showing promise now, that is getting certain compounds fast tracked. And interestingly, ianalumab, which we talked about kind of a lot in the symposium, is a 1-2 punch in one medication. So I think this sort of combination dual action approach is what has really, and it's been going on for years. It's not like somebody just thought of this 6 months ago, but it's the original trials to do this dual action starting at the beginning of COVID. And so then everything got slowed down, but we're getting, I think, pretty close to having something to offer our patients, which is really exciting.
Oh my gosh, it's so exciting. I'm now telling my patients about this, and in the hopes that it gets approved. I hope it gets approved, because I think it could be a game changer for some of our patients. And, which kind of leads me to my next question. So if we do have a therapy that's effective for Sjögren's, how should we as APPs, what can we do to better identify patients with Sjögren's, manage patients with Sjögren's, out in the community, maybe the primary care setting? What can we do to get these patients in?
To get them in, that's a very good question, because there's all the diagnosis issues where a decent proportion of patients, up to 30 to 40 in some studies percent, don't have the autoantibodies, the SSA, SSB. So that makes it a little more challenging for us. But you're right, getting them in to get tested in the first place is the bigger challenge. So much the same way that we do with gout, with partnering with our podiatry and ortho colleagues and our primary care colleagues and saying, look, if you see this kind of a thing, please send them our way. Same thing needs to be happening with Sjögren's, with dry eyes, dry mouth, probably the low-hanging fruit, neuropathy, any sort of family history of autoimmune disease, to sort of get that word out to primary care. I think ophthalmology is very, very aware. We get a lot of referrals from ophthalmology. But so that, hopefully that partnership will continue. But yeah, getting the word out to primary care, to let them know that this is something that maybe we can help with, and this would be an appropriate referral, and we'd be happy to see these patients.
Well, and again, to that point, it's also, I think we do a good job as APPs of really asking the right questions, but also just getting the word out that, again, Sjögren's is multi-systems, and, many things are involved, and that it's not just about the dryness, right?
Mm-hmm. Right. Yeah. The primary might even was probably even saying you probably have Sjögren's, so just keep doing your drops, But yeah, you're right, getting the word out that it's systemic, and that's just the tip of the iceberg. And it's almost like a warning signal that there's probably something deeper going on. And maybe with these new medicines, and even some of our old medicines that we use off label, we can at least slow down the progression and keep them from having some of these outcomes that we don't like to see.
Absolutely. So you did mention that there's this percentage of people that don't have the antibodies. This is kind of a loaded question, but do you send a lot of people for lip biopsies? No, I don't either. It's becoming a little bit more popular. Patients are asking me about it, and I've sent patients if they're insistent on it, but at least thus far I haven't, because truth be told, it doesn't really change what I do if it's positive or negative.
Right. Yeah.
Yeah.
We do them. We do send patients if we're really struggling to nail down a diagnosis. But it hurts, and it's more than just a little shaving off the top of the skin or something. There's a couple stitches. Some patients have a little bit of nerve damage. They can't feel that part of their lip anymore, the inner lip. So we do it. We're not opposed to it, but it's not something we jump right to. We get the ocular staining score or the Schirmer's test, or just even a good ophthalmologist to say, this is what it is. And, if they do have the SSA or SSB, that kind of makes it easier.
Oh gosh, yes. Yeah.
And family history and their personal history. And these patients, whether they have a lip biopsy that confirms it or not, they deserve a trial of treatment in many people's opinion.
Yeah, absolutely. I think what will really be interesting is if we do get an FDA-approved medication, if we will be ordering more of those. I don't know. I mean,
we might need to.
Yeah, just to kind of help really differentiate what's going on.
Because everything that's coming down the pike is a biologic of one sort or another. So it's going to require authorization and possibly some diagnostic criteria. So We'll have to see what comes with that one.
Absolutely. Okay, I have one last question for you. So looking at the key takeaways that, we hope that our listeners bring back to their practice after this conversation, why should people come back to the RhAPP conference next year, Betsy?
Well, they should come back to see what happened with all these fast-track medicines we talked about today.
Absolutely.
One reason. And then no matter how much progress we make, there's more progress that we could be making, more education needs to get out there. Maybe this year is going to be the year for Sjögren's and next year is going to be the year for systemic sclerosis. Who knows?
Absolutely.
So keep coming back because rheumatology is never boring.
Never boring. And I think we've just built such a wonderful community together, you and I.
This is just, like I said, it's just like coming home.
I love that. Well, with that, that's going to wrap up today's episode of RhAPPcast. A big thank you to Betsy for sharing your insights and helping us unpack the evolving landscape of Sjögren's disease, from its complex pathophysiology to promising and emerging therapies that go really beyond just that symptomatic care. If you found today's discussion valuable, make sure you come to the next RhAPP National Conference. It's the premier event for all of rheumatology advanced practice providers. It's really education for APPs, by APPs, really keeping you up to date with the current, most, greatest education. Stay tuned on RhAPPcast for more episodes featuring expert conversations, conference highlights, and case-based learning that supports your practice. Until then, we'll see you next time.